Hey, what's up, everyone? Welcome to the Duly Diagnosed podcast, the podcast where we discuss all things mental health related. Today, we've got two psychologists in the studio, both of whom are in private practice and who also provide psychotherapeutic interventions to patients at ARC Recovery Center. Polly is a clinical psychologist with a special interest in neuropsychology, and Lario is a counseling psychologist with a special interest in relationship dynamics and systems. Today we're going to be discussing dual diagnosis and specifically the role that clinical psychologists play in the treatment thereof. So thank you both for joining us today. It's really a privilege to have you with us in the studio. I think let's get right into it. Let's start off with what exactly does dual diagnosis mean? What is it?
Okay, thank you. That is a very important question, and thank you for having us. A dual diagnosis is just a co-occurring diagnosis to the substance use disorder. So what that means basically is that a person with a substance use disorder has a co-occurring existing other primary diagnosis of a mental health condition. So there's a lot of mental health conditions that are seen repeatedly co-occurring with the substance use disorder. Sometimes this mental health condition plays a part in the cause of the substance use disorder through people trying to self-medicate the symptoms of to treat the symptoms of the mental health condition. And at times, the mental health condition is also the perpetuating factor in the substance use disorder. Otherwise, on the other side, it can also be vice versa, where the substance use disorder is part of the cause of the mental health condition.
Polly, I want you to tell me a bit more about the process that you go through when identifying co-occurring disorders that might co-occur with a substance use disorder.
Okay, so that can be quite a very difficult process because a lot of the times we get people come in at varying states of their disorder, and so they might not always be the most reliable when it comes to giving us appropriate history. So it's very, very important that we do a good assessment and evaluation. So everyone that comes in with a substance use disorder needs to be fully evaluated to see whether did some of their pathological behaviors occur before the substance use, or does the pathological behaviors and emotional states only occur during the use of substance use, exclusively during substance use or substance intoxication or withdrawal, so that we can differentiate whether it's pathological behaviors or a mental health condition that's caused by substance use, or is it a mental health condition that existed prior the substance use.
It sounds like a really time-consuming process.
A lot of time, and we also rely a lot on the family to give us that collateral and that background history. What was the person like before the substance use? What is the person like on the substances and even off the substances? Just to get that that good collateral and comprehensive picture for the person. Yeah.
Okay. Lorio, so I think you probably have a good explanation for how that process takes place. Do you wanna elaborate on that?
Okay, so I think, as Polly said, our patients, and that could be for several reasons why they might not be as reliable in the beginning to give us appropriate information, but they might also be quite resistant for us to actually involve the family, especially so early in the process. Often, when patients arrive at a rehab setting or at any facility, they might already have felt ambushed or in some way pressurized to buy into the program itself, because the family is often the ones that contact us first. So it's very important in the first few sessions, like Polly said, in the assessment process or evaluation process, to explain to the patient, him or herself, exactly what type of role the family is going to play in the process, but also to help them understand why we need the family or loved ones. It doesn't necessarily have to be family members, but any support structure, why it's very important for them to form part of the process. We need to help them understand that we're not there to work against them, we're all there to work together for a common goal. So at the end of the day, I think it would start by having a honest, open conversation with the patient with regards to when and how we're going to involve the family, because obviously we do require their consent in order to get the family involved. And then if they have any questions in terms of what we might ask the family members or the loved ones, then we can obviously elaborate on that. And I would find that it's often beneficial to have or to meet with family members individually. You sometimes find in a family dynamic that one family member might dominate such a session and they might talk more than other family members, where, as an example, it might be important to get information from a sibling, as an example, and not just from a parent, or from a parent and not just a partner. So to spend really that one-on-one time with each supporting member of the patient's family or support structure is quite important.
Okay. Polly, tell me a bit more about your special interest in neuropsychology and what exactly neuropsychology is in a nutshell.
Okay, so neurocognitive just involves a lot of the brain. So the neurological underpinnings of based on how it influences behaviors and the functioning of the person. So it's a lot of the cognitive functioning, cognitive processes and thought processes that are involved in making who you are, basically. Yeah.
Okay.
So Polly, I think I would like to ask two questions, but I think I'll start with the first one. Right in the beginning, you said that there are some common co-occurring mental health disorders that seem to coexist with, specifically with substance use disorder.
Yeah.
Can you maybe elaborate a little bit more on what would be some of those common mental health issues or disorders?
Well, there's quite a few. There could be, for example, some cognitive mental conditions such as maybe ADHD. We've seen a lot of the times that children that had ADHD are vulnerable to developing a substance use disorder, either in their teens or in their early adulthood later on in life. But other mood, mental health conditions such as maybe your anxiety, your depressive disorders, your bipolar disorders, those present with a lot of symptoms and behaviors that are very difficult for the individual. And in order to cope with those mental or mood fluctuations, people will oftentimes then self-medicate. And therefore, that starts the relationship with the substance use. Yeah.
All right.
Yeah.
Okay. And then, I often get questions from the family members asking me that they are quite uncertain or confused in what role the clinical psychologist plays versus the psychiatrist. So can you shed some light with regards to, what each one's role would generally be?
Okay, well, the psychiatrist and the clinical psychologist, we both deal with psychiatric mental conditions. All right, it's just that the psychiatrist will be more medical based, right? And then the psychologist will be based more in the psychotherapeutic work. So how most mental conditions work is that there's a cluster for the pathological behaviors that are involved in the condition, in the criteria, and also some psychosocial issues that are involved. And then there's the physiological, more pharmacological part that is also based, the biological part of the disorder. So then the biological, physiological part is mostly dealt with the psychiatrist and the medical team. And then all the other psychosocial, behavioral, emotional, and mental parts of the criteria of the disorder, that's where the psychologist comes in through that psychotherapeutic work with the patient. And we deal through that in that psychotherapeutic relationship.
Okay.
Yeah.
Right. So Polly, you mentioned earlier that the patients aren't necessarily always as reliable in terms of giving the appropriate information.
Yeah.
Now, I think we often find that also we have some difficulty in keeping patients engaged post-rehab, especially in important aftercare processes. So can you maybe explain how one can, or how important, firstly, is aftercare in terms of dealing with a dual diagnosis, and how to kind of keep a patient engaged in that process?
Yes. So oftentimes, like I explained, a lot of substance use disorders have repeatedly been shown to co-occur with other mental health conditions. The unfortunate part is a lot of people go undiagnosed with a mental health condition, and then the substance use is a byproduct of the mental health condition, and then they do get admitted, and then they deal with the acute symptoms, and then they leave out and thinking they can go back to their life as normal. But if those underlying mental health conditions and psychosocial issues are not treated and not dealt with adequately, then that causes a huge risk factor for them developing the substance use disorder again. So it's extremely important, not only initially when the patient gets admitted, that they are fully evaluated. So using all the assessment tools for the emotional functioning, personality, and then also looking at the psychosocial factors, and then also getting that collateral from family. But then also in the treatment plan, once we've stabilized them and we've dealt with the acute symptoms, that they still get the care to assist them going further. So dealing with those underlying mental health condition and then also the psychosocial issues. So they need that continued support from the team. Yeah.
Can you maybe elaborate a little bit more on what would a comprehensive aftercare plan involve?
Okay, that's a very important question. Each individual gets their own unique treatment plan based on what we evaluated initially when they came in with their substance use disorder, and then of course based on their co-occurring mental health condition. But with all or most mental health conditions, there's a biological component or the physiological component, then there is the psychosocial component. So then that biological component is taken care of by the medical staff or medical practitioner or psychiatrist. And then we deal with the psychosocial, emotional, cognitive part of the disorder, and that's taken care of by the psychologist, the clinical or counseling psychologist in the psychotherapeutic relationship. And then we deal with the social part as well. And then that also is dealt with the psychologist, but also other avenues are as well available. And it's very important that people are aware of the resources available to them. So we have the psychiatric institutions and recovery centers, but we also have DSD, which is the Department of Social Development, which can be a really great resource as well. And in communities, there's also support groups, various support groups that are available, which are more focused groups with people that have gone through similar experiences and have similar histories or conditions as well. And then also, of course, there's sponsorship as well available to them. So it's important that people use those resources. And then, of course, family is a very important resource to have. But if family isn't available, unfortunately, some people live in those realities where they don't have as much social support. So it's then important to use other resources and infrastructures that are available in their community, like the Department of Social Development, like the recovery centers, and being part of an outpatient therapy basis with your psychologist as well.
So mutual self-help groups and self-help groups in general seem to be lacking when it comes specifically to dual diagnosis. Besides dual diagnosis being a relatively new concept in South Africa, why do you think there is such a lack of those kinds of support structures, specifically for dual diagnosis patients?
Well, I think it is quite essential to have groups like that. Unfortunately, there aren't as many, but the issue is with dual diagnosis, it's very broad and very individualized. You know, if I have a substance use disorder, but with a co-occurring specific mental health condition like depression, that is very, very different from someone who has a bipolar substance use disorder as well, like a co-occurring substance use disorder with bipolar, for example. Those two individuals look very, very different, and their symptoms also occur very differently and have very different perpetuating behaviors and pathological behaviors. So cannot really be treated in the same way. They have very individualized treatment plans. So that's where that individual level one-on-one kind of therapy is so important, and that's where that also comes in as well.
So, Polly, tell me how a clinical psychologist would know the difference between somebody with a pre-existing mood disorder and, say, somebody who comes in for a session with a Red Bull hangover.
Many different substances have the effects of those substances mirror and look like a lot of other mood disorders, and they fit the criteria, right? The only thing we need to look out for are those symptoms exclusively present when the person has been using the substance or during intoxication or during withdrawal. And that's why when we do the clinical interview as a clinician, it's so important to find out what kind of substances did the person ingest recently within the past day or the past 2 weeks. It's so important because the effects of those symptoms, those substances can have an influence on what they present with as well in front of you. And you also need to find, can I make a distinction between someone who has a pre-existing mental health condition, or is it something that is induced by a substance? And a substance like Red Bull that has a lot of caffeine, there is such a thing called caffeine, mood disorder secondary to caffeine, or caffeine-induced mood disorder, for example. Yes.
So, Polly, I think there's loads of family members and including patients that would often ask, how would a psychologist be able to assist me with something like an addiction problem if they themselves have not had personal experiences with that specific issue or problem? And that's why a lot of individuals might opt to only make use of resources involving individuals who have suffered or is currently struggling or has struggled with substance-related issues. So what would be your take on something like that?
No, I totally understand that question, and I get that question so often, and it's absolutely valid. How can you understand my world if you've never been in my world? So I understand why people will say that and have that query. It's just that you need to understand that the psychotherapeutic relationship isn't just like any other relationship. We are coming in as objective spectators and researchers into your life, where we investigate you and your life and the dynamics between not only your substance use disorder, but also the mental health condition that you have, and then the pathological behaviors related to that. And we're looking at that dynamic and working with you based from an evidence-based treatment plan for you. So we come in from a very objective point of view. And there's, of course, the element where we're sitting in there in that one-on-one situation where we are trying to empathize and really truly put ourselves in your shoes so that we can really truly empathize with you, but still having that evidence-based present in that therapy room and in that treatment as well. So only going one route is too one-dimensional to only deal with substance use, just going to the meetings. It's just a little too one-dimensional, at least initially as well.
Okay, so what you're saying is it might be best to have a bit of balance in terms of getting different perspectives and opinions on how to deal with a specific issue or problem.
Yes.
And as we said, it's eliminating the possibility that the professional might project some of their, if they were to have struggled with a substance use disorder themselves, that they might, project some of their own subjective experiences or feelings, even emotions, onto the patient's clinical picture.
Yes, absolutely. If I'm too intertwined into your world as well, that's also a danger, because I project some of my maybe fears, maybe insecurities, and too many of my ideas, personal ideas, onto you. And this is still your journey. So as a psychologist, maybe I might not have gone through what you've gone through, but I'm so objective and I'm working from evidence-based that I'm able to assist you in a way without projecting too much of myself into the relationship and into your healing as well.
So in a nutshell, anyone in early recovery essentially needs all the help that they can get at any given time.
Yes, because you present multidimensionally. There's different facets involved in your presentation. It's hardly ever just linear. This caused this. It's hardly ever. It's many different things that caused the presentation that we see now. So it's biological, it's psychosocial, it's emotional. Ideally, we try and work from a very, all of us, whatever medical profession you're in, everyone in the medical profession, we all try to work from a very objective standpoint. And we try to see each case as a new individual case with its own unique treatment plan that follows based on what we see. So we really do try to not overgeneralize each person that we see. And ideally, I would think anyone who sees a patient would work from the same kind of ethical standpoint, that each person is a new case with their own treatment plan that is unique to them, that will assist them best that we can.
So I've never had a clinical psychologist take a blood sample, send it to a lab for testing, get the results back and sit me down and tell me, how my borderline personality disorder is getting out of line or out of hand. Tell me about the process that you take to test for mental health issues as a clinical psychologist.
Yeah. So with each person, the interview is part of the test as well. So the clinical interview, that's why in the clinical interview, there's specific questions that we have to ask, either to rule out or rule in certain pathologies. Then also, we have a lot of battery of tests that we do as well with you in the session, right? Some projectives where we assess for emotional functioning and personality functioning. And then also we have a lot of cognitive tests that we can also administer to you. Some are long, some are short, but also checking your cognitive functioning. And based on that, and then also, of course, collateral from your family. So your behavior outside of the room when you're with us. So outside of the room, the behaviors that you exhibit outside as well, your emotional functioning outside, and how you've functioned throughout the years as well from the family. That is also part of the battery of assessments that we do. And then there's also some things that we do to rule out certain things, whether is it the behaviors that we're seeing, is it due to another medical condition, or is it due to a substance, or is it purely a mental health condition? Yeah.
But I think it's something you don't necessarily have to complicate, because I think there's various other diseases that gets diagnosed without blood tests. Let's take something like asthma. I mean, I can go to the doctor and only explain my symptoms, and they would already say, okay, well, your symptoms sounds like, or concur with a classic asthma. So let's apply the treatment, and if it works, then, it's kind of a trial and error type of situation. But I think, like Polly said, the clinical interview already checks or asks for common symptoms of the disease of addiction, which is things like the fact that there is powerlessness, that one's life becomes unmanageable, that there's often that despair and isolation. And, if those symptoms are all present, it's safe to say, but it's always that one can go on observation in terms of what the patient is experiencing, to be able to have more or less an idea, which you then obviously confirm with the appropriate clinical tools or assessments or evaluations.
Yeah. Just like any other illness, with mental health conditions, we also have like those specific criterias, that the person needs to meet in order for us to diagnose them with a specific type of mental health condition. And then each mental health condition, right, because it involves very specified, unique type of pathological behaviors that go with it, and emotional functioning that goes with it, and psychological functioning that goes with it, then the treatment plan will also look very different. So I can't treat someone who has an anxiety disorder, whatever type of anxiety disorder they might have, the same way I would treat someone with a depression, for example, or a depressive type of disorder as well, because there's more than one type there, and there's more than one type anxiety disorder, for example. So each one is really quite individualized. And with psychology, it's just so intricate and very comprehensive that it's not just the symptoms that I'm seeing now that I am treating, but also the perpetuating factors that are involved in what I am seeing. And then also things that happened in your past that maybe you might need to heal from. So it's quite a lot of things that we're dealing with at the same time. That's why each individual person that comes in front of me has to be treated individually and uniquely.
So people who use drugs or who pill seek aren't necessarily always honest with healthcare professionals. Let's say somebody, tells you what they think they want you to hear so they can get their wife off their back or get her out of treatment sooner or, motivate you to give a referral to a psychiatrist for medication that they might abuse, things like that.
It's almost like alluding to like malingering.
Yes.
What
Yes.
else
Yes,
can they
yeah.
get from the treatment? So there are actual tests that you can look out for. And also within the clinical interview, you ask specific questions either to confirm or to rule out. And within the clinical interview as well, you'll get to see, okay, this I might need to investigate further because this criteria of behaviors or symptoms doesn't go with this kind of what I'm observing, for example. And that discrepancy already, then we will try to investigate further.
So, Polly, you've trained for many, many years to get your qualification. I'm guessing that must have been quite a hardcore process.
Oh, absolutely. It's quite a long journey, and I think Lario can say as well, and every other psychologist out there can say as well. It's quite an extensive learning and training process, from undergraduate until your master's. So for most, it takes about 7 to 8 years to really become an actual practicing clinical or counseling psychologist. Yeah, so it is quite a long journey. I don't
Cool.
know.
Okay, cool. Thank you guys for joining us today. I think it's been a very informative meeting and episode, and I think what I took from it mostly was that as anybody with a dual diagnosis needs to get all the help that they can get at any given time, especially in early recovery. And there is no substitute for good quality professional interventions. Hey, so I'd like to thank you guys for joining us today in the studio. It was very, very informative, and we'll hope to see you soon again.
Great.
Okay,
Thanks for having
awesome.
us.
Thank you.
Cool.